The savings, we look at it two ways. One is when it's dispensed to the patient, bill the insurance and apply their GPO or contracted rate to that. And that will get them what they would have paid in the past. And then the second piece is the cost of the goods on the shelf, which now are consigned, that they used to carry that cost of ownership and now don't.
Without supplies, there's no surgery. Without products, there's no patient care. Welcome to Power Supply, the healthcare supply chain podcast focused on helping you navigate the intricacies of logistics, purchasing, contracting, and supplier relationships. Each episode, we speak with healthcare executives, supply chain leaders, and innovative entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the loading dock to strategic sourcing, from buyers to the C-suite, and across the enterprise, we tackle the real-life issues impacting the healthcare supply chain. Whether you're tuning in for conversation or inspiration, we're glad you're here. You're just in time to hear it from the source and stock up on insight. So sit back and plug into Power Supply.
On this episode of Power Supply, we are going to be speaking with Jeremiah Smiley, Regional Director of Supply Chain Operations at Multicare, and JJ Anderson, Senior Director of IDN National Accounts at Breg. And Gary, they're right in your neck of the woods there. We're going to be having a conversation around creative sourcing solutions and non-acute spend management. We're going to learn a lot about the concept of stock and bill today. I'm so excited.
You know, I like the conversation and the definition of what this is going to be and how we're going to understand it with our listeners as they hear their conversations with Jeremiah and JJ, and the partnership. It sounds like that was created, some synergies that we're going to hear about in this space. And I think this is a theme. I think we talked about it with Hayes and Justin and our producer, Aaron. I think this is a theme. We're going to see more and more about these partnerships and success stories in 2025 as Power Supply. So looking forward to the dialogue today. That's going to be a good one.
All right. It's all about collaboration with Jeremiah and JJ up next.
Bam! I'm Hayes Walder.
This is Gary Skinner.
And I'm Justin Poulin.
From the studios of Healthcare HQ, you're listening to Power Supply.
We're speaking now with Jeremiah Smiley, Regional Director of Supply Chain Operations at Multicare, and JJ Anderson, Senior Director of IDN National Accounts at Breg. And this is going to be a conversation, or I should say, highlighting a case study in collaboration. This is a topic we have not talked about before. It's about getting really creative in the world of sourcing around non-acute spend management. We definitely haven't talked about the concept of stock and bill. So we're going to be covering all of that today. I want to welcome you both to the show. Jeremiah, maybe you could introduce yourself to the audience and tell us a little bit about how you find yourself in the role you're in today at Multicare.
Yeah, thanks, Justin. Hey, my name is Jeremiah Smiley. As you had mentioned, I'm the Director of Supply Chain Operations for the Inland Northwest region of Washington State and North Idaho with Multicare. I've been here for 6 years. Prior to that, I was in the Army for 5.5 years where I was a medical logistics officer. Went to school at Pacific Lutheran University, received my undergrad in business, and then after leaving the Army, I went and got my MBA from Eastern Washington University.
Great. So many people in healthcare supply chain today, started in the armed services, I feel like. There's just so much supply and logistics that go into the planning. And, when you talk about healthcare and being, having kind of like a critical mission and things have to go right because lives are at stake, I think the parallels are part of the reason there's such a strong, correlation to that. Does that resonate as true for you, Jeremiah?
Yeah, absolutely. I think I have several colleagues that are all veterans that came from the medical logistics community, whether that be Army, Navy, Air Force, into now the civilian sector, and they do the same thing. It was a great opportunity, and they work well together.
Well, Jeremiah, thank you for your service.
Thanks for your
definitely
support.
Want to acknowledge that. And JJ, let's let's introduce you, because you're the one that reached out to me and said, I've got an interesting story that I think would be good for the podcast. And so maybe talk about kind of your background and your time at Bragg, and maybe even tee up a little bit for the podcast about why you reached out. What was it about Power Supply that kind of called your attention to us for this conversation today?
Yeah, thanks, Justin. Thanks for having us here and for the question. Nothing quite as noble as Jeremiah's past, in all honesty. I've been to the Army Navy game. I don't know football game, but
well said.
But other than that, I can't claim much there. But no, I appreciate the opportunity to be here. I've been with Bragg for going on 16 years in different roles, and been on the national accounts team for the last eight or so of those years, really working with health systems in our categories of how do they want to manage our space, and are they interested in revenue opportunity? Do they want to avoid cost? Or they just want to standardize and have a formulary, those types of things. And, really, really passionate about our space. And in general, I think health systems haven't, taken the time and put the energy that MultiCare has into this space to really maximize the patient care, the efficiencies, and the business opportunity. And that's why I think, at least in my seat, this is a really interesting story. I think what Jeremiah and team have done is an example for other health systems.
So JJ, I'm going to give you the honor of defining stock and bill for the folks out there that are not familiar in that. And then Jeremiah, maybe you can fill in any details from the provider perspective as well. And then we can talk about maybe some of the difficulties, with stock and bill historically.
Yeah, and I think nothing too revolutionary here, but stock and bill is consigned product that the health system doesn't own, that is there with the intent to bill insurance for the product instead of billing the facility. That can be, a third party. Obviously, Bragg's in this business, but a lot of other folks are. But it can also be an entity within the health system, and that's something that's come up more and more. So I don't know if that helps or does a good job, but
Just a clarifying question, JJ, and before Jeremiah jumps in, is that inventory on consignment, stock and bill, is that managed by an institution of yours, or is it managed by staffing at the hospital system? I was just curious, or is it a hybrid model, or is there options? Just want for our listeners to be clear.
Yeah, really great question. And I think they're all there. The standard is that whoever owns that inventory. So in the Bragg case where we're providing the stock and bill or the outsourced program, Bragg would manage that product, move it around within the locations where it happens. Some sites that's not ideal for, and they would prefer to move it around. And so there's certainly some of that.
Helpful.
And Jeremiah, where did you find some struggles in stock and bill? Right. And I think just Gary's question is a great one. There's some variability there, around how it's managed, and who's kind of taking ownership of sort of stocking, right, depending on the health system or even the location within a health system. But what are some of the other challenges from the provider standpoint that could help kind of paint this picture of what stock and bill is, and what a lot, we'll come back to kind of your prior state to this project and start outlining the case study from there.
Yeah. So there's several ways that you can do sort of the stock and bill. One is in the non-acute space at the offsite locations, the clinics where Bragg, DJO, PacMed, you name it, whoever, they'll manage that product. They'll show up, they'll check the shelves, they'll restock it, and then they'll go away. And then in the hospital as well, you'll find, at least in this case, durable medical equipment, DME, boots and bracing in the ORs and the EDs and the ICUs. And I think one of the areas that probably the majority of health systems struggle in is some departments want to manage it themselves. And other departments, they want the third-party vendor to manage it, right? So then there's this gray area of who's doing what for each of these departments, and there is no standardization, right? There's no standard approach of who actually owns this process. And so then what you run into is, running out of product, which then leads into one department, hey, I used to work on the ICU floor. Let me go downstairs and I'll just take from them real quick and take it back upstairs, right? And then you have this introduction of shrink or of product that's been taken without being dispensed properly. And ultimately now, third-party vendor, whoever that may be, can't bill that patient's payer to get their money. And so what happens is, hey, guess what? This happened in your facility, multi-care, whoever it may be. Here's the bill for your department. So now the department is eating the cost of those products that should have been dispensed, properly to the patients and then billed to that payer.
So I know the audience doesn't get to see the cameras, but Hayes, I'm seeing a lot of nonverbal communication. Do you have some familiarity with stock and bill? I got to know.
Yeah, back in my old days, I went in the orthopedic space. We clearly, we consigned a ton of inventory, but it wasn't quite the same. But it's interesting how Jeremiah started talking about, one department goes and steals from the other department, and then they start hiding them and all that stuff, so they always have it. So I could clearly see good parts of this and some negatives as well. But clearly it seems like it makes a lot of sense for the system.
Already we've had a lot of conversations early this season around standardization and the opportunities to be standardizing. And I think a lot of times, I'm a clinician myself, but I feel like we're getting better, but a lot of times the clinical departments don't understand the actual impact of non-standardization on clinical outcomes and patient care. And I feel like it's just a constant educational opportunity around that. And so I just want to highlight that theme because I feel like it's going to play out a lot in our conversations this season. And Jeremiah, as soon as you said that, it's like, right, there's just a high degree of variability. So how do you centralize your sourcing approach when everything is done inconsistently? And you're a large organization. So what did that look like before you sort of started to re-engineer this process prior to the pandemic?
Yeah, great question. So the Inland Northwest region comprises really eastern Washington and parts of North Idaho. And then the Puget Sound region would be west of the Cascades. And that's kind of how MultiCare's geographic region plays out. And so in the Inland Northwest, we have the Rockwood Clinic. And since the beginning of time, the DME specific to bracing and supports was managed in-house by a Rockwood employee. The boots, the braces, they would be at those ortho clinic sites in the non-acute space. They would be dispensed from those sites to that patient, and then they would be replenished all by that Rockwood individual. In doing so, the Rockwood Clinic network was able to collect that revenue. On the Puget Sound side, much larger, much more clinics, more hospitals, you name it. They had always had the stock and bill approach. And so they would have, at the time, it was a mixture of Breg, PacMed, DJO. They were servicing these clinics, these ortho clinics, as well as the hospital space, and restocking the boots, restocking the braces. And then they were dependent on the accurate paperwork being filled out by those multi-care employees so that they could then bill the payer. If the paperwork was not filled out correctly, right, we get back to that same concept where Breg can't bill the payer, so Breg's going to bill, or whoever, PacMed, DJO, they're going to bill somebody, and at the end of the day, that's multi-care. If it was done correctly, then they would bill the payer, and third-party vendor would then collect that revenue. And so when I saw that discrepancy or that non-standardization, I kind of scratched my head and said, hey, why do we do this? How can we become standardized? And we began going down that road. We went out to RFP. Third-party vendor was selected, Breg. That's how I met JJ, and we began standardizing the products across the system. So we began first with switching, I believe it was Rockwood side, because we were with a previous vendor, so we became Breg, and then we began implementing the standardization of Breg products across the Puget Sound region. Once that was all the same across the board, we then began to work on how can we bring this work in-house for MultiCare to do the stocking, the dispensing, the billing, therefore, then eventually the collection, right, to get that revenue and keep that in-house for us versus having that go to a third-party vendor. That project took probably in total 18 months. We had to get a lot of buy-in from clinicians. We had to do a lot of sourcing and contract work. We had to do a lot of education, right? We had to implement a new software system. We had to integrate that with our current ERP. It took a tribe, right? Like a lot of different people to get this across the finish line. But At the end of the day, we were able to do it ultimately now, at least in our non-acute space. We're all Breg product. We're all on a digital platform now versus paper. We're able to collect that revenue for the health system rather than let that go to a third-party vendor. There is a time and a place for a stock and bill, and typically that's within the hospital walls. We can't bill for those DME items, right? You can in the non-acute space, but you can't within the hospital walls. And so that's where we have JJ's team predominantly do the stocking and the billing for those DME products in the OR, in the ICU, in the ED, as well as our off-campus ED sites that we have throughout the city.
No, I think it's good. And I think this is a lot of education for our listeners that are listening about this. I think this is a really good white paper study in it. And I know there's some Medicare rules on billing, probably on the Breg side. And I want to assume, but I want to clarify from Jeremiah and JJ, there was, as you went out to RFP and then you awarded moving towards Breg, you offset some of that pass-through expense that you maybe were seeing that wasn't billed in a timely manner. So that stock or that inventory that the hospital had in the ED and on the floors and those par levels, a lot of times if it's not acquired by the entity, we have to pay for it at the hospital, correct? So I just maybe a little bit of clarity on that just to make sure, because I see savings. I'm seeing savings and I'm getting kind of excited about it. So I want to make sure I'm tracking with what Jeremiah and JJ, you're talking through with that kind of that DME world, no ortho soft goods.
Yes, I think I understand your question. And if I don't answer it or if I say something wrong, JJ, please go ahead and take it over. I have seen across our system and in different health systems. So Multicare has 11 hospitals in the health system. I have seen areas where, for example, let's just call it the ICU, where they will purchase, say, the crutches and the boots and the braces on their own dime and then dispense that to a patient, and then the patient walks out the door with it. And those costs we do have to eat. Now, I guess where the savings piece comes in, I think what you're alluding to would be where a stock and bill, a JJ or a Breg, a DJO, they come in and then they manage that product. And therefore, when the nurse takes the crutches, the boots, and dispenses it, the third-party vendor, they are then able to bill that patient and their payer. Therefore, the payer is paying for the product versus the hospital just giving it away. Is that kind of where you're?
Yeah, that's where I'm tracking exactly. JJ, does that make sense in your world?
Yeah, absolutely. And in general, I mean, this is becoming more and more popular, but historically even Multicare years ago in their EDs were just giving away, hundreds of thousands of dollars of product that they were carrying the cost of that Medicare has dictated are billable items to insurance. And so that I think you're spot on. And that the savings, we look at it two ways. One is when it's dispensed to the patient, build the insurance and apply their GPO or contracted rate to that. And that will get them what they would have paid in the past. And then the second piece is the cost of the goods on the shelf, which now are consigned, that they used to carry that cost of ownership and now don't.
No, it's just a really good point. And I think you guys have demonstrated the partnership needed to engage that. There's a ton of training as well with the clinical staff, correct? Like you are on site, you are supporting the clinicians, you are managing that inventory. I mean, there's a lot of labor that goes into that as a true partnership. Not only on just the bottom line showing that there's savings, but there's also an operations, logistics, education, if you will, on, a 5S project. That's what's underneath the water here. Like, what is the steps to maintain that, to get it accurately to the patient and support our mission, right?
I'm really glad you asked that question, Gary, because even as we were defining stock and bill at the beginning, the whole reimbursement model is very unique from other sourcing initiatives. And it was a really good call out. There's a lot of nuance to stock and bill to begin with. But JJ, I think you described it really well, that, in a lot of cases, the supplier partner is billing insurance directly for the health system. But then there were all these areas where you'd have stock that essentially went unaccounted for and unreimbursed. And there's a huge opportunity as the squeeze, I think, on especially during the pandemic, that the finances of healthcare you had to look for everywhere you could to try to get the ship back, to a point where, you're operating on that really healthy 1% margin, right, Jeremiah? So let's talk about like, what was it that happened, right around the pandemic that led, you and the team at Multicare to start looking at this differently? Like, was it the financial pressures, or were there other factors that led you to dive in deep on this?
Yeah, I think there's two main drivers of that. One being the lack of standardization, as I mentioned previously, how one region was doing it one way and the other region was doing it the other. But then also, yeah, it was the pandemic. Everyone, across the nation, health systems became financially strained, and we were trying to find ways to save money, to make money, whatever you could do. And when I had stumbled across this opportunity to, one, standardize across the system, and then two, develop a larger revenue stream, because we were already kind of doing it with Rockwood and getting revenue from that clinic side, which was at the time 4 ortho clinics, to almost increasing it 5-fold, because there were 17 ortho clinics on the Puget Sound side. It was a great opportunity to help generate revenue and try to stay in the black and out of the red, so to speak. And it just happened. It was more or less a coincidence that we were going out to RFP for DME bracing and supports at that time, where I had met JJ and we began this journey.
So were you doing a lot of this on Excel sheets and transposing paper? Like, what was, like, before you said, okay, we've got to like put a technology in to really get, obviously the data is going to help us do something at scale, and it needed to be done at scale to get that standardization that you're talking about. What was it, on spreadsheets? Was it paper?
Yeah.
Was it both?
I'll talk about sort of how it worked in the beginning, and then JJ, he probably is a lot more familiar with the product and how it works now. But yes, previously, one region was kind of on a digital platform, maybe 2/3 on a digital platform and 1/3 on paper. And that's where the majority of the errors occur, because you miss checking this box, or if you don't really talk about medical necessity, or you forget to have the patient sign, you don't get a bill to payer, you're eating that cost. Whereas on the digital platform that we had at the time, as well as what we have today, it's more or less kind of like an Amazon checkout, right? You have to have your credit card information. You have to have this, or you can't advance to the next page. So same sort of concept, where you have to have all of these fields filled in before you're allowed to dispense that piece of DME. And so on the Puget Sound side, they were all paper since the beginning of time. So there was lots of discrepancies, lots of shrink, lots of, Multicare having to eat the cost of these products. And then we introduced Bregg's Vision platform, the digital platform, and our efficiencies have they've gone through the roof, increased exponentially. It's been rather incredible. That was just in the ortho spaces, those non-acute locations. And now what we're doing is implementing that same platform within the hospital walls, in the EDs, in the ICUs, in the ORs, and we're looking to gain more efficiencies there as well. JJ, did I miss it? Or sorry, go ahead, Justin.
One of my last roles as a nurse was doing medical necessity reviews for a third-party benefits administrator. And so I'm like very familiar with that process of like, having to have the right documentation going back to the payer. And even when I worked at nursing homes, I did a lot of intake coordination. And so like, just how you fill that out. And I even did home health, and, very clear on how much gets kicked back if it's not filled out correctly, or sometimes you just don't get paid. And there's a huge amount of inefficiency. But I think for most healthcare organizations, that becomes a rev cycle problem, not a supply chain problem. And yet here you are. And again, just pointing out the nuance of stock and bill, you're kind of waffling, on who owns this a little bit. Does an initiative like this bring you closer to the rev cycle team? Does this kind of a project bring the supply chain team closer to the rev cycle team just by, that little element of billing a payer, where you don't necessarily have that with a lot of the other items that you're sourcing?
Yeah, absolutely. It gives you a seat at the table, right? And now you're just as listened to as your rev cycle partners, and you get to help make and guide decisions on these type of DME billing, the products, where it's dispensed from. So yes, absolutely, Justin.
So I have a quick question for JJ, and on that side, on your side of the table, do you set the par levels of how much product is going to be there? And obviously, it sounds like the software is probably pinging you guys to know how many are being used. But are your folks going in there and actually, or who's literally going in and putting them back in the facilities and things? Are your team, or is that the hospital side?
Sure, yeah, and I think, we use the term hybrid for what Jeremiah and team have implemented, in the sense that in those non-acute orthopedic clinic settings, they're generating revenue, so they own the product, they're billing insurance, and so they're utilizing. They've set par levels, and they control. It's within some software Bregg's developed called Vision that Jeremiah mentioned, but they control the par levels, they control the reorder points, and they do that through their distribution partner, and so there's we Bregg products at the warehouse. It's they're the next day type thing. And then for the outsourced or stock and bill locations that still exist, because of the relationship and the integration that we've done with ERP and EMR, that's available for all the stock and bill locations that historically were paper and inefficient for the end user. So in those cases, we have agreed upon par levels that Multicare expects us to meet or to have on availability, but our teams are managing those pars.
Gotcha. So they're literally going in every couple of weeks or whatever and replenishing and making sure they're up to those levels.
Yeah, more often than that in general, but yes, absolutely. So it's mostly the hospitals and the urgent cares that are in that stock and bill setting. And I just add, this is Multicare's and from top to bottom been an exceptional partner to work with. But and I just add to 2 points. I heard very early on in the RFP that this technology piece was critical to their initiative, and that they had that to add to the standardizing and the financial piece Jeremiah spoke to. I think that coming up with a workflow that was better for all of the end users was critical to, hey, if we're going to spend time on this, we can't be on paper anymore. Is that fair to say, Jeremiah?
Yeah, absolutely.
So now talking about technology, right? There's the obvious, you've got real-time visibility to data. You don't have to transpose something like aggregate data onto an Excel sheet, comb through rejected billing to figure out what had happened with each individual use case. Like, I can see some of the, the obvious sort of things that would lead to efficiency and all that. But Jeremiah, maybe you could outline, what has, now that you're on the other side of implementing technology, what are some of the real key benefits to getting this off of paper and Excel? And, how many conversations do we have in healthcare supply chain about lack of technology and, how many processes we're doing in this manual way? Obviously the big push is to get, towards a technology, but there's also a lot of leadership in healthcare supply chain that says, yeah, it's great. You can go out and spend a lot of money on a technology, but if you don't leverage it, you're just adding cost to the system, right? And what sort of seems very unique about this scenario is that it's a targeted technology that manages a very specific workflow. So you're not necessarily worried about underutilizing components of it that you've paid for that you then can't actuate on, right? So I hear that's kind of, I think that's prevalent in this conversation. You can definitely adjust that a little bit, but what really made this so valuable to you now that you can look back at it? Because you had some ideas, but now you've realized it.
Wait, was there a question in there?
I think I was answering it as I was talking.
That was about a 14-minute question that I don't know what the question was.
Let me do that again. Let me do it again. So fair enough, Hayes. Jeremiah, more simply said, what are the main benefits from having the technology now that you can look back at it, right? So that's it.
Yeah, some of the main benefits, I would say, clearly what we've discussed already is getting off of paper, right? That was all manual, prone to various errors. Now it's very succinct, it's quick, it's live. So that's great, and that improved the efficiencies. Number two, I would say, is previously to Hayes' original question, hey, how or who sets the par levels? Beforehand, it was all, tribal knowledge, right? It was that ATC or that individual who worked at that clinic. Oh, we do about this many a day. There was no digital, sort of log of how many boots we dispense, what sizes, how often, that you could easily access. Sure, you could go back and look at purchase history and try to piece that together, but now it's all on one platform, broken down by site. I can see Breg has fantastic dashboards. I can see, what size, where it was dispensed, how many, even down to, who was the payer, right? If we're talking about Premier Blue Cross or Medicare, or you name it. So that, I think, has been an awesome piece of data that we never had clear visibility to before, was that piece. Lastly, one of the efficiencies that we have yet to recognize, we're going to go live here, I think, in maybe 4 weeks, is integrating it with our ERP system. So today, and again, Hayes, you kind of almost touched on this when you're asking about par levels. In the ortho space and the non-acute, we set the par levels, we being supply chain, in collaboration with those clinicians that work on site. The individual at the site, when they dispense the product to the patient, right, it gets decremented from Breg's Vision platform. And so now we have all of these clinics dispensing product and decrementing. What we've had to do today, even still, is go in every day and kind of watch and see, okay, they're getting kind of close to the reorder point. Let's start to build a PO, and then we'll issue the PO and it'll go out. And so it's that manual piece that I'm trying to fix, of us having to go in and look at all these things every day, every other day, and monitor it. We've recently implemented, we left Lawson, so Multicare is now our ERP is Workday. We've been working on this integration. JJ, we've been working with Michael Green, a couple other folks from your team, with the idea that now Breg, again, in 4 weeks, Breg is now able to talk to Workday. And so it'll pull those decrement reports out of Vision, place them into Workday. Workday will then work as it does with all the rest of our warehouses, where once it reaches that reorder point, it'll automatically generate a PO. It'll automatically send it out. We'll get replenished. Those items will then be delivered to those specific ortho clinic sites across the system, ultimately removing that last manual piece of us having to watch things every day, right? It'll just automatically do it like any other perpetual inventory does at a warehouse.
Sounds pretty smooth once it gets going, for sure.
Fingers crossed.
Yeah, exactly. JJ, my question might be, obviously we're talking about multi-care here, but obviously if we pull up on the 20,000 foot level, other hospital systems out there, how many are using something similar to what you guys are offering? And is this a problem everywhere generally? And it's just kind of a new technology that's come, basically putting all this together with your platform. Is this all something fairly new that others are starting to do?
I think I'd answer in a few ways, but, health systems are just like probably all categories, somewhere in the journey in this category, right? And so much like Jeremiah was at Multicare, years ago, they were giving that product away in the hospitals. They went to a stock and bill, and then they, acquired some places, got some revenue, saw what that was, and then, came to us and asked for data and then validated the opportunity and took it broader. So everyone's somewhere in that process of still giving away, or in some areas, maybe stock and bill, or in some areas, still revenue. It's generally, I'm meeting with the health system early this morning, that they're trying to figure it out, right? They got the revenue people getting involved to say, are we generating revenue here? We don't really know. So that's probably a standpoint. And then more and more, though, I think it's become a situation where they see Medicare said these are billable items. We should not be just giving them away. We don't really do that elsewhere for things that are billable. And so I think that's becoming more prominent. The technology piece, and there's a mix of folks that are happy to be on paper and that works for them. But I think more and more folks are, it's 2025 now. We can't do this anymore. This isn't efficient for our end users. And I think that push the technology comes from, both a clinical standpoint that Jeremiah hit on, of like, our nurses and staff need to be super efficient. And two, that billing efficiency and that piece. I've literally been somewhere where they told me their goal was how short their paperwork stack was, right? From trying to enter it in and bill it to the insurance, which is just doesn't sound fun.
No, not at all.
I'm going to take another crack at asking a succinct question. Jeremiah, one of the other things that you told me about as we prepped for this was that you had expanded it to the clinical procedural areas. So like traditionally this is seen as kind of a non-acute, non-clinical spend, and yet you kind of climbed, into those departments. Why didn't you do clinical and procedural areas before, and how easy was it to expand? And I think that's a big part of the case study that we need to tell here.
Yeah, I think I would say the majority of the procedural areas across the system, they were already on some type of stock and bill, whether that was DJO, Breg, PacMed, but they weren't all, not everybody was standard being on stock and bill. Some of them were, like we spoke about, were just purchasing it themselves and dispensing it themselves and just eating the cost. We got into the procedural areas because I knew it was just waste, right? We were just giving product away. It is a lower hanging fruit. It is easier to do than to try to get into the non-acute ortho clinic spaces and do all the rest of the billing, the dispensing, and having to have FTE that are able to do that, and the various other resources. So it is easier to do as far as setting up a stock and bill, because at the end of the day, I'm not doing the work. It's JJ's team doing the work. It's just us getting buy-in from that procedural area director, manager, whoever's overseeing that area.
So your non-acute team starts moving in and having these conversations with relationships that you hadn't necessarily established before. Did you leverage JJ and his team to help kind of scale that up and move along more quickly and do some of that outreach? Because, again, it's just an area that you probably didn't have those established relationships. So when you're asking somebody the first time they're probably meeting you or a member of your team, right?
Yeah, absolutely. JJ and team, they've been instrumental in the success of this program. We relied on them heavily in the beginning to help. We would establish the relationship. Hey, this clinic manager's name is Justin. We'd like you to come out and meet him. And then they would help articulate in a better way that we could the benefits of, hey, this is why we're going to bring this in-house. Yes, you will have some additional work, and that additional work is, instead of JJ's team showing up with a boot and putting it in the closet for you, now it's going to show up via FedEx, and you have to have an individual, a HUC or a CMA or whoever you deem necessary, that then takes that FedEx box, opens it, puts the boot on the shelf. But with that additional work comes this exponential revenue stream. And so, yes, JJ's team was instrumental in helping us get that across the finish line.
All right, we're getting pretty close to the end, but I'd like you to kind of paint a picture for what's next. All right, so, I mean, I get the sense that you guys are not done. You've had some success here, and you want to build on that success. So where do you go?
Yeah, great question. Our next step on this DME journey is, I think that we've hammered out the bracing and supports DME pretty well across the system. Another area, or the area that we're looking to next, is going to be CPAP and bringing that in-house. That is outsourced across the system. CPAP is a little bit more, perhaps a lot more complicated in bringing in-house, as far as being able to dispense and bill a payer for the product and then collect that revenue. I've been working on this now probably for the last 12 months. I am optimistic that here in 2025, we will open up a DME storefront in our region in the Northwest, where we will begin to dispense CPAP to patients that come to multi-care facilities, have a sleep study done, get prescribed a CPAP. They will then go to that DME storefront, be issued that CPAP as well as the soft supplies, and then we will help that patient with their CPAP needs. It'll be great. For two reasons, really. One is patient care. There's a lot of patients aren't in compliance with their CPAP use. And when you're not in compliance with your CPAP use, the payer will not pay for that product, right? And so, one, their payer's not paying. But two, and more importantly, is that patient is now not getting great patient care, right? We need to keep them compliant. We need to help make them stay on their CPAP. And oftentimes reasons for non-compliancy is the mask is uncomfortable, the pressure is too much, it's too little. And by bringing that in-house, we will have that sleep doc, we will have that sleep team readily available for that patient to reach out to and to contact. Whereas today, we have these larger organizations where customer service may be lacking, or a patient may just be disgruntled with the service that they're receiving. And so they'll say, I quit. I don't want the CPAP machine on anymore anyways, right? And that reduces our patient care across the system.
Yeah, it's definitely the impact of accountable care. And, if your reimbursement's going to be tied, and they don't say, non-compliant patients anymore, but, if they're not able to, maintain their treatment plan or the care, and then that's all of a sudden hitting the hospital, and you see it a lot more conversationally around readmissions related to getting discharged for surgery, and then having a surgical site infection that's related to not doing wound care on the right schedule. And so all of a sudden health systems started owning healthcare agencies that would do that, so that they could start to learn more about how they can prevent that additional admission, post discharge. And especially obviously if they go to a competitor in the marketplace, now you're paying list price instead of eating the cost internally. And, it makes a lot of sense what you're saying there about why you would want to advance your program to include, CPAP for that very reason, is just having control over process improvement at a level that you just couldn't control before. We're at the end, but I could dive into that one. That maybe that's the next podcast. We could revisit this in a year and talk about, the case study on the nuances of implementing that CPAP program and how it was different from stock and bill, and that compliance piece. Following the treatment regimen is definitely uncharted, innovative territory for a lot of health systems. So, Jeremiah, anything you'd add before we wrap?
No, I just want to say thanks, Justin, Gary, Hayes, JJ. You guys have all been great. Yeah, happy to be here and happy to have a great partner in JJ and Brad. Great collaboration, and we've got more work ahead of us.
Well, as we wrap up, I just want to say I appreciate both of you being here, because to me, this is what we're all about. Is we've got to work. Providers and suppliers have to work together to solve these issues. And as great and as competent as you are, Jeremiah, and your team, it's something they really couldn't do well without the help of JJ's team. And to me, that is what we're all about. And I just want to, applaud. And if there's other people out there listening to this who have other ideas and other things that they'd like to bring up, please reach out. But I really appreciate both of you guys doing it and being here today. Thank you.
And JJ, I'll give you an opportunity for final thoughts, but I'm glad you brought that up, Hayes, because also that's another theme that's been emerging is collaboration and creating transparency and finding new, unique ways to bring the provider and the supplier together to tackle that. So this is also the second episode in a row that's been a strong theme. And to your point, Hayes, I think we need to continue to see those themes coming out in a lot of the conversations that we're having. But JJ, anything you want to add before we wrap up?
Yeah, and I really appreciate those comments as well. One of the things I was hoping would come across is why I think this has worked I'm supportive of this, but our local team has really been heavily partnered with Jeremiah and his team. And so I wouldn't say I'm on the outside, but when I look at multi-care and why this has worked, I think there's a culture of leadership and accountability there that gives them the freedom to work on something like this, which I think isn't everywhere. But I also think they were really clear from the beginning of the RFP on what they were trying to solve. And that allowed us to be really focused on what we thought would be meaningful to help them to get to where they wanted to go. And then just a commitment. I love our space and the fact that we can find a project like this where we are literally pushing together and it's mutually beneficial, which doesn't always start that way when you first cold call someone, right? And so it's really neat when you get to there, and then just the prioritization on both sides, and just simple things of having regular set communication and the leadership Jeremiah and his team has. So hopefully that wasn't too far off track, but I appreciate where Hayes went there, because I think that there are things within multi-care that made this the right time for this project and to make
great synergies.
Yeah.
All right. Thank you
well
both.
Done.
Great job.
Great job.
Yeah. Thank you, guys.
That was Jeremiah Smiley, Regional Director of Supply Chain Operations at Multicare, and JJ Anderson, Senior Director of IDN National Accounts at Bragg. And it's really a case study in tackling, a project to move from, paper processes that are all done differently across a large organization, and then bring forward a technology to really tackle that, give better insights, better control, and ultimately impact patient care. I just think that when JJ reached out to me, Hayes, he's like, I think I got a good story, but, I'd love to pick your brain on it. And I was like, there's concepts we haven't discussed on the show that's involved in this story. And then to your point at the end, which I think was really important, is just continuing to highlight suppliers and providers working more and more closely together to solve these challenges.
Well, I learned a lot actually about the stock and build process. I'll be honest, I didn't know much about that part of it. But I think to your last point there, the whole goal of all this is we all have to work together and be smarter about it, be more efficient about it. So the whole concept of this podcast today was really well done, and Jeremiah and JJ had a lot to offer. So I thought it was really well done, and I thought it was very helpful for me.
All right. Well, that's going to be a wrap for this episode. On behalf of Hayes and Gary and myself, thanks for listening to this episode of
Power Supply.
Thank you for listening to this week's episode of Power Supply. As a reminder, you can help support us by subscribing on your favorite podcast app or by downloading the smartphone app on your iPhone or Android. Simply search for Power Supply in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@powersupplymedia.net. We look forward to hearing from you.